Hi, this is Dr. Keneth N. I'm the Director of Weight Loss Surgery here at Rome Health. Thank you very much for choosing us for your weight loss surgical needs. In the video to follow, join me as I uncover everything that you need to know regarding obesity, obesity-related diseases, and their associated surgeries. See you soon.
The purpose of this video is to provide information and education as it relates to people who are interested in having weight loss surgical procedures. And I'll be serving to uncover many questions or concerns that you or your loved one may have. I will uncover what is obesity, what is the fundamental issue, why are some people overweight, obese, and some people are not. I'll also seek to uncover what are the associated challenges that you are already aware of. What is the cost, be it financial or otherwise? And most importantly, what are the current surgical options available? Let's talk about obesity. In 2013, we in the bariatric community were very excited when the American Medical Association finally considered obesity as a disease. What this meant was people with obesity and obesity-related conditions could get the care and the respect that they needed. Certain medical procedures relating to obesity would finally be recognized, and also people in the bariatric community who understand and understood at that time that bariatric surgery is the key to helping some of these people overcoming their obstacles were very excited. We also hoped at that time that it would mean that people would be more sensitive to the needs and issues related to people who are overweight, and that the insurance companies will increase coverage for those who may be severely in need. Obesity, in the simplest form, is just a process or a disease process in which fat is accumulated in the tissues to the extent that it impairs your health. Your tissues will function in an abnormal way, and as such, your normal day-to-day function may be affected. You are not alone. Your loved one's not alone. According to the CDC, approximately 42% of adults and 19% of children are obese, and that number has increased significantly over the years. And by 2050, approximately 50% of the American population is projected to be obese or morbidly obese. Causes. Now, there are several different causes as it relates to why people are obese and some people may not be. Now, scientists have uncovered an interplay between genetics, behavior, and the environment. Genetics simply talks about the genes that you inherit from your parents, your grandparents, and the generation prior. Behavior has to do with your own particular contribution to your weight. For example, many of my patients, they have sedentary lifestyles, and as such, they do not use as much energy during the daytime, and ultimately, over time, that may or may not lead to obesity. The environment has to do with what does the community, society on the whole, how do they contribute? Oftentimes this relates to fast food, etc., and we'll discuss that a little bit later in other slides. There are also several other contributing factors which may play a role, including the family, social scene, culture, that's big, access to healthcare, education, economics, the community, and of course education as it relates to knowledge and a particular belief set. As it relates to the environment, we have learned several lessons. Portion sizes have gone up significantly. In the 50s, for example, portion sizes in general, particularly from fast food chains, were much smaller. And what have we learned? The bigger the portion size, the more the calories, and that will take a significantly much longer time to burn up. And over time, that will lead to weight gain. As you have seen on this slide, most companies over the years have significantly increased their portion sizes, and that in part has contributed to the epidemic of morbid obesity. Let's take a bagel for example. 25 to 30 years ago, the average bagel was about 3 inches with approximately 140 calories. Nowadays, depending on where you get it and the size, and all the additives that typically goes along with a bagel, such as cream cheese or butter, coffee with cream, you can have a combined meal caloric intake of anywhere from 700 to 1,000 calories, sometimes even more. Now, why is all this important? Primarily because there's a lot of health consequences that can be sustained from people who eat unhealthy or people who are obese or morbidly obese. Now, there's several different ones. I've highlighted on this slide 3 of the most important ones: sleep apnea, hypertension, and diabetes. Now, of all these, the one that seems to be much more common and much often seen in people who are overweight or morbidly obese is diabetes. And diabetes is one of those multi-system disease that affects several different areas. And because of that, we're very concerned. But the good news is, with bariatric surgery, and not just me, according to the National Institutes of Health and other such organizations, bariatric surgery and sustained weight loss is one of the main means by which you can attain a cure. So most of my patients, luckily, after several weeks, will have obtained a significant reduction in their glucose numbers, and shortly I've seen approximately 80 to 90% of my patients come off their diabetic medications, and most of these patients will go on to attain a cure. Now, there are many serious health consequences related to obesity, and this can be lumped up by way of systems. Now, no system is safe from this dreaded disease called obesity. We have people with lung conditions, and these can be lumped into one category called pulmonary diseases. A lot of my patients will have depression at some point in their life. Strokes are much more common. Heartburn, what you call the metabolic syndrome, pancreatitis, cancers such as breast cancers, colon cancers, uterine cancers, all these are much more common with people who are morbidly obese. I've had a lot of my female patients with fertility problems. PCOS, which is polycystic ovarian syndrome, is often very common in people who are obese. Fatty liver disease, osteoarthritis, which is the bone-on-bone arthritis that we so commonly see. That does not go away with weight loss surgery. However, the pain and sometimes the inflammation does. So these are all the systems that we see that are affected by morbid obesity. Now, if you have a loved one who's morbidly obese, or you yourself are morbidly obese, you will know that there are significant challenges that you will face on a daily basis, much of which I will not be able to uncover in this lecture. But let's take a look at a few. Going through the turnstiles at the train station or public transit, going to the movies with family or loved one, going upstairs, playing with your children, often can be emotionally and physically taxing. Now look at that last slide. I had a patient who I did approximately 8 years ago, and every time I see this slide it reminds me of this particular patient, because he told me, "Doc, I was that patient. I was that one who had to ask for the extra strap while being on a plane. I was that one that every time I got on a bus or in a public area, people would look at me a certain way, and look at me now." So there is hope. There is hope, and we will guide you through this process. There are many obstacles, but having weight loss surgery, having this sustained weight loss will make a significant impact on your life. Just follow me, and I'll guide you through that process. Now, how is obesity assessed? How is it qualified? How is it determined? Now, there's several different systems, and of course, typically your primary care provider or your doctor typically is the first line of defense. It's the first person that will tell you, hey, look, you're doing something wrong, or you're overweight because it said so on your scale, or you're developed diabetes or hypertension, and oftentimes they'll tell you, look, if you lose 20 pounds or 30 pounds, or if you get on this diet, you may or may not be successful. Sometimes your doctor also will put you on certain medications. But typically, the first line of assessment is your primary care provider, and that's the one who typically assess you. Now, there are different systems, and one of the most commonly used system is the BMI, or Body Mass Index. That's a very common scale that's used throughout the United States today. Now, the BMI basically measures obesity based on height and weight. It basically says how heavy you are for your weight. And there's a scale, as you can see in this slide, which starts from just shy of 18 and goes up to over 40. Now, as it relates to insurance protocols and qualifications for surgery, most people will qualify with a BMI of 35 and above. And that's where morbid obesity typically starts. Now, if your BMI is 40 and above, typically most of these patients will qualify for weight loss surgery without needing any medical problems. Now, why do we care about obesity? Why do we care about BMIs? Well, as you can see, as your BMI increases, so does your obesity, or your morbid obesity, depends on where you are in the scale, and your chances or risk of death increases significantly. That's correct, and I've told this to all my patients, even at the first visit, because it's important for you to realize this is life-altering, and in fact, many studies have shown a significant improvement in life expectancy. Many patients would have gained 8 to 10 years on their life. I've operated on many patients over the years who I believe would not have been around had it not been for that significant interventions. So it is extremely important to see where you are, assess where you are, and take a step at getting that under control. Let's investigate the cost. What is obesity costing you, your family, your mother, your father, your brother, your sister, you, your household? How does it affect you? There's several different costs for obesity, and they can be classified several different ways. Let's look at conventional treatments. Now, many people have been on many commercial diet programs. I've seen this ever since I was a kid. There's all these programs that you subscribe to, that you pay. They can be extremely expensive. Oftentimes they are not effective, and compliance has been a big issue for most of these. Most people will start, but they'll stop because it's very inconvenient, it's expensive, and oftentimes unattainable. When that doesn't work, oftentimes your physician may offer weight loss supplements or medications, but most of these have added costs, are not covered by most insurance companies, and you have to also worry about all the side effects. Let's look at day-to-day living costs. Clothing are much more difficult to find, more expensive. Food costs are much more expensive. Medical expenses go up exponentially. As your BMI go up, your obesity goes up, so does your medical problems, which means your pharmacy costs will be much more, your doctor's visits will be much more. Medical admissions and surgical procedures are much more common in people who are morbidly obese. And lastly, not listed on this slide, but something to note. On average, it costs a family approximately $25,000 to $35,000 per year in the United States as it relates to obesity and obesity-related issues. This is cause for concern. Now, one of the most important topics relating to weight loss is weight loss surgery. So patients often want to know, doctor, what are the options? Okay, you got me, you have my interest. Where do we go from here? What are the surgeries that you think are best for me or for my particular circumstance? Now, there are several surgical approaches available. Gastric banding is still available in some areas, but we as a program have moved away from gastric banding for several different reasons, which I won't completely get into here. But let's just say there's been an unacceptable complication rate that we have seen over the past 10 to 15 years. The most commonly done procedure in this country in 2020 is actually the sleeve gastrectomy. The second most common surgery is the tried and true Roux-en-Y gastric bypass. And I'll explain the difference between the sleeve and the gastric bypass. Lastly, still being done, is what's known as the biliopancreatic diversion with a duodenal switch. And this procedure will not be done by our program for several different reasons, and I will not get into those, but it has to do with complications and difficulty with patient compliance. So for the next few slides, I will be going over the surgical aspects, particularly the ones that we do here at Room Health. Who qualifies for weight loss surgery? As I alluded to in the slide before, anyone with a BMI of 35 and above may qualify. Now, most insurance companies are looking for comorbidities. What do we mean by that? Obesity-related diseases such as your diabetes, your sleep apnea, and hypertension. These are just some of the examples. And oftentimes patients will come to me and say, "Doc, I'm healthy, I have no medical problems." But you'll be surprised what we find once we do a preoperative assessment, sending out labs, sending you for sleep studies, etc. You have to be healthy enough to undergo an operation. So oftentimes we'll send you to your primary care providers, your pulmonologist, your cardiologist to make sure that you're medically optimized and you're fit enough to tolerate surgery. Oftentimes the insurance company would like to see a failed attempt at medical weight loss. So patients often will tell me, "Hey, doc, I've tried this weight loss method, it has not worked. I've tried this medication, it has not worked." And oftentimes insurance companies would like to see that, so we'll document that. It's important that you abstain from drug or alcohol. It's important that you do not smoke. If you're actively smoking, now is a good time to stop. A nicotine patch is not a substitute because the nicotine can have very bad effects on surgery. Most importantly, you have to be dedicated to this significant lifestyle change because there will be a lifestyle change, and I want you to be prepared for what's going to come next. Now, let's look into some of the procedures. This is what you call the lap band, or the proper name is the adjustable gastric band. Now, this has been around for many years, and this slide is just for historic accounts only, just for you to see. There's this white, almost plastic-like structure that goes around the upper stomach, and the concept was you would place fluid in that tubing. The plastic tubing would get smaller, and that would restrict the amount of food that you can take. The issue is there's been a lot of problems with erosions, which means sometimes the band will cut into the stomach and cause a perforation. There's been esophageal problems, etc. And for that reason, we are no longer using this product. Now, I've seen a lot of patients over the years who have had the lap band done, and oftentimes what we do will convert you from a band to a sleeve or a band to a gastric bypass. That's called a revision surgery, and we do that procedure here in our practice. The sleeve gastrectomy is one of the most commonly done procedures in the United States. This is restrictive, which means that it reduces the amount of food that you can eat per serving or per time. And there's also a metabolic component, which means there's a chemical change which occurs in the stomach over time. The end point will be the reduction in the amount of calories that you'll take in, and this will in time lead to significant weight loss. This has been around now for several years, and it's been tried and true, and this is the procedure of choice for most patients. Okay? The beauty about this procedure is that there's a normal absorption. What you eat is what you get, and it's much more natural compared to some of the other procedures. In the next slide, we'll show you a brief video which explains what a sleeve gastrectomy entails.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
The gastric bypass surgery is the gold standard surgery. It's been around the longest and it has the greatest experience as it relates to weight loss procedures throughout the entire world. Now, there's slightly more rapid weight loss with this procedure. There's no implants required like the sleeve gastrectomy, but unlike the lap band surgery, and it works very well for most patients. This is ideal for patients with a higher BMI. For example, patients with a BMI over 50 or even over 60, and oftentimes there are other reasons why this may be more suitable. So as you come in and see us, we'll evaluate your particular circumstance and we'll help to guide you as to what procedure may be best for you. There's a slightly higher complication rate overall with the gastric bypass compared to the sleeve, and there's a slightly higher maximum weight loss seen at a year or 18 months versus the sleeve gastrectomy. But overall, they're very similar, and they're done in a very similar fashion by laparoscopic or robotic techniques.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
Now, why is all this important? Why surgery? Why not trying to do it yourself? As you have seen with The Biggest Loser, there's a landmark article that came out in the New York Times several years ago that all the members of The Biggest Loser, I believe at least the first episode, not only gained weight back, but most of them did gain their weight back plus additional weight. What we're saying is it's extremely difficult to be compliant with just dietary and lifestyle changes. Why? Remember my first slide, we still have the individual, we still have the genetic contribution, and we still have the environment, plus all the different pressures of work, social pressures, etc. And this makes it extremely difficult for a person who is already morbidly obese to lose weight and to sustain weight. What we're looking for is sustained weight loss. Now, if you look at gastric bypass surgery and sleeve gastrectomy and other weight loss surgeries and combine them, if you examine these patients over time, you see most patients, approximately 95%, would have lost their diabetes, 92% would have lost their hypertension, heartburn, high cholesterol would have gone away, sleep apnea, etc. I operated on a patient who was actually on the transplant list for cardiac surgery, and we were able to take that patient off. There is significant improvement in cardiac function, which is why it's so important to consider weight loss surgeries, especially when all health fails. Now, what are the complications that you can see? Overall, weight loss surgery is extremely safe in the hands of those who are skilled to perform the procedure. We've seen a few cases of bowel obstructions, vein thrombosis, bleeds. People talk about leaks, though they are extremely rare, except for your high volume bariatric center, wound infections, etc. We have done, and we have incorporated in our program several different techniques and strategies to reduce these complications. For example, we'll get you up walking right away, immediately after surgery. We'll give you compression devices on your legs. We'll give you medications to help to prevent DVT, and we'll get you using your GI tract as soon as possible. Most patients will be able to go home within 1 to 2 days after surgery, and this shift have led to significant improvement in patient overall satisfaction, patient outcome, and a tremendous reduction in complication over the years. In summary, this is how I recommend dealing with the whole aspect of obesity, weight loss, and weight loss surgeries in general. Maintaining a healthy weight is a balancing act. If you take in more than you use, you will, of course, have weight gain. If you burn more than you take in, you'll have weight loss. It is a balancing act. What will help you do is, first of all, get to and attain that healthy weight. We get you close to that ideal body weight as possible. That healthy weight in which your function will be optimal. And once we'll get you there, we'll guide you and help facilitate health maintenance. To put it all together, the first line of defense against obesity or morbid obesity is lifestyle modification. What is that? It's physical activity and it's dieting. When that fails, most people will go to pharmacotherapy, the medications, the weight loss supplements, etc. And for a great subset of the population, the obese population, it's limited. After 3 months, most of these medications will not work, or it's limited by the side effects. And then at the pinnacle is bariatric surgery. It's not for everyone. Certainly come in and see us, and we will help evaluate you and determine what's the best course of action. Choosing the right procedure for you, it's a combination of several different factors. Your age, your medical problems, the amount of weight you're expecting to lose, your lifestyle, whether it's sedentary or active, what medical problems you may have as it relates to whether or not you're on steroids, etc. Ultimately, there's a mutual decision between the patient and the surgeon. We will figure out what's best for you, obviously with your guidance. In so doing, we will set expectations. In general, people undergoing the sleeve gastrectomy will have lost most of their weight at 1 year to 18 months. Approximately 70% to 75% of the excess weight loss will be attained at that point. As it relates to the gastric bypass, which, as I said before, is slightly more effective for some patients, at 18 months, most people will have attained either their ideal body weight, or most people will have attained a reduction of approximately 78% of their excess weight. Now guys, you've stuck with me over the past several minutes. I've tried to uncover all the important information that you need to know in order to make an educated decision as it relates to bariatric surgery for you or your loved one. So congratulations, you have done the single most important thing. Now what is the next step? Schedule an initial consultation with us. We'll do several things, including verifying insurance benefits, authorization. Most patients will need a psychological evaluation, a nutritional evaluation, evaluation by your gastroenterologist, sleep studies, cardiac evaluations, and of course preoperative testing. Once all that's done, providing you have gone through the necessary steps as dictated by your insurance companies, we'll schedule you for surgery. Surgery is done by minimally invasive techniques At Rome Health, we're doing laparoscopic surgery. As you've seen, they're all very tiny incisions, which means less pain, faster recovery, and quicker time you get home to your family and your friends. Most importantly, this is a lifelong relationship between the staff, the surgeon, and the patients at large. We'll make sure that you're successful and we'll be there every step of the way. Why Rome Health? We have had an extensive experience as it relates to weight loss surgery by our surgeon. We're well adept at minimally invasive surgical techniques. We're widely respected surgical practice, but most importantly, we can get you in the door really quickly, and we have an understanding, very caring staff. I wanted to show you a few pictures of one of my patients in the past who have given me permission to show these pictures. This patient had a sleeve gastrectomy. This is a before picture, and the slide to your right is approximately 9 months to 1 year after surgery. This is what you call a lifestyle change, and believe you, surgery is just a tool. You do have to have the right attitude, and you have to be willing and ready to do some work, and we will guide you along the way. Thank you very much, and I'm looking forward to seeing you in consultation.